The effects of this disease include more than half of the reasons people age 50 and older die. It's the number one cause of heart disease, stroke, blindness, kidney failure, erectile dysfunction, permanent disability, and death. It's associated with depression, chronic fatigue syndrome, Parkinson's, Alzheimer's, cognitive decline, regardless of age, and many more diseases. Many scientists say it's the common origin of most chronic disease. What is this disease, you might ask? It's a metabolic disease. What is that? We'll cover that. So how do you fight metabolic disease? Well, first, you have to know if you have it. Get proper testing. Understand it. Be aware. Awareness can allow you to avoid premature death and disability, improve or eliminate many other diseases, allow you to get off medications and their side effects. Often when your doctor prescribed them, she or he didn't understand what they were doing anyway. You'll feel better. You'll regain your energy and your mental performance and your libido. In this video, we're going to share with you how to open up the landscape of your metabolic health. We use a battery of tests to determine your level of metabolic health or disease, ranging from energy transportation to burning to storage. Now, that means carb or fat transportation, burning, and storage. We'll explain each of these tests and give specific examples of solutions we've provided for other individuals as we have guided them on their way to better health. Consider some of these examples for your own journey. Whoever you are, no matter your age or genetics, no matter how good or bad the shape you think you're in, we've yet to meet anyone that we couldn't help dramatically improve their metabolic health. First, let's define the problem. Now, there's this thinker, Gary Taubes. He wrote a book about that middle-age spread, gaining weight as we age. He called it Why We Get Fat and What to Do About It. Most of us think we're adding weight because we're eating more, but it's really exactly the opposite. It turns out we're eating more because we're already adding those pounds. It's a real head scratcher, right? Well, it turns out it's hormonal. We're beginning to lose the ability to metabolize our fuels. Here's where it gets interesting. Our bodies are like, no, I just can't do it, to burning the energy we've got stored up, all thanks to this sneaky thing called insulin resistance. It's like trying to start a fire with wet wood. It just won't light. We can't burn the carbs we're eating, so our blood sugar goes up. The high blood sugar makes our insulin go up, and then high insulin stops our fat burning. So whether it's the carbs we're munching on or the stash we've got in our fat reserves, burning it becomes a no-go. And here's the twist. Digging deeper, there are three major culprits behind insulin resistance. The ticking clock, yes, aging, getting older. How much we tip the scales. And it's not just obesity. I'll explain that in a minute. And the cards we're dealt, genetics. Now, if you're wondering about the obesity part, well, how heavy is heavy? It's more of a sliding scale than a simple yes or no. It's not just about being fat or obese or not. It's about the amount of body fat you're carrying and where it's located. You see, we're also eyeing the visceral fat, the fat that wraps around your organs. And as we said, when sugar levels in the blood start climbing, so does insulin. And here's where the plot thickens. High insulin levels throw a wrench in our body's fat-burning gears. It becomes a vicious spiral. All right. Let's break down how we shine a light on insulin resistance for folks, diving into the nitty-gritty with three key players. The first is the Kraft Insulin Survey. It's also called an oral glucose tolerance test with an insulin response. But you don't have to remember all of that. We'll remind you. The next key test is a deep dive into the way fats are transported in your bloodstream. It's known as a lipid panel with fractionation. And finally, we take a peek at your cardiovascular inflammation markers. We kick things off by watching how your body deals with a sugar curveball, tracking blood sugar and insulin, to see how swiftly they can tuck that sugar away in your liver and muscles, where it's at least safer than in the arteries. Next up, the lipid panel with fractionation is like a detailed dive into how your cholesterol and fat energy transport molecules, or particles, are working. While most doctors are eyeballing LDL cholesterol and calling it the bad guy, we don't stop there. We dial it up a notch with fractionation. It's like taking a closer look under the hood, seeing the size, density, and distribution of those cholesterol particles, because it's not just about the numbers. It's about understanding how your cholesterol and energy transport particles morph in response to the real troublemaker, metabolic disease. But wait, there is more. The buzz about inflammation, it's getting louder and louder, and for good reason. We deploy a quartet of tests to get the scoop on cardiovascular inflammation, sifting through the data on markers like microalbumin creatinine ratio, C-reactive protein, that's the high sensitivity kind, myeloperoxidase, and LP-PLA2. If those sound confusing, hang on. Again, you don't need to remember all of that. Once we've got those cardiovascular inflammation markers, we lay it out for our patients, painting a picture of their carb processing prowess, or lack thereof. And as they start connecting the dots between carb troubles and inflammation, a light bulb begins to go off. They realize they're not just dealing with a little carb confusion. It's a full-blown inflammation party affecting their arteries and cholesterol, muddling up not only their LDL, but their HDL and triglycerides as well. That's the moment the motivation kicks in, and they begin to see the full landscape of metabolic disease laid bare by the lab results. Now let's talk about the insulin survey for a minute. It has two parts. The first is called a glucose tolerance test, or OGTT. It measures our glucose levels after that sugar curveball. When we toss glucose your way, we're watching to see how your body plays the game, how it moves that sugar through your bloodstream, dodging inflammation alarms, and parking it, at least somewhat safely, in your liver and muscles. It's all about this carb dance, how your body processes those carbs from the beginning. Here's the next part. We're tracking your blood sugar levels, sure, but we're also keeping an eye on how much insulin your body needs to keep those glucose levels in the sweet spot. Maybe pun intended. And it simply boils down to that. So you might be wondering, why do we use this test when other docs don't? Well, here's the thing. Most docs do a hit and run on LDL levels and just rush on to the next patient. Sure, they've heard that diabetes speeds up the express lane to heart disease. But most have even gotten an inkling that diabetes is even more deadly than LDL cholesterol. It's like the lights are on, but nobody's home. A study from Johns Hopkins by a group led by a fellow named Singh, T-S-E-N-G. He and his group highlighted the major problem. 3 out of 4 doctors are out of the loop on nailing down prediabetes. Now, we're not talking about orthopedists or rheumatologists or allergists here. We're talking about family practitioners, internists, and cardiologists. 3 out of 4 of them are out of the loop. They don't know how to make a diagnosis on prediabetes, the early stages of metabolic disease. So if they don't know how to diagnose it, how well do you think they treat it? So the test we're talking about, the insulin survey, it's like a crystal ball into the early whispers of that metabolic mayhem. This mayhem creates what we've dramatically dubbed the insulin spiral of death. Yes, we might be oddballs among doctors for having our finger on this pulse, but we're backed by the same research from Singh and his crew at Hopkins, as well as Joseph Kraft. You remember, the guy that created the Kraft insulin survey. You see, that research points out the gap in mainstream medical wisdom. While the standard practice is to glance at LDL, and maybe for some, they even look at ApoB, and then they hustle to the next patient. That's barely scratching the surface. It's not just the doctor's hustle that's to blame. It's the playbook they were given. It turns out a lot of them weren't really trained on the ins and outs of metabolic disorders back in the day. Now, most of them did know or hear that diabetes was a thing, but they were clueless about the havoc prediabetes wreaks, touching every cell, every tissue, right down to the cholesterol-carrying particles. You might have heard them called lipoproteins. And most never even heard of the term metabolic disease. Peek at the stats, and you'll see that by the time the medical world hands down a diagnosis of diabetes, 1/3 of these folks already have their eyes taking the hit. They had damage to the back of their eyes, diabetic damage, before the diagnosis of diabetes was ever made. There's a double whammy here. Prediabetes isn't just what your mom's doctor called a touch of sugar. It's doing damage. And doctors and their patients are catching on way too late in the game. So the moral of this story is, if you hear a doctor say, you've got a touch of sugar, just a touch, be afraid, be very afraid. Now, about this insulin survey, this test has patients and docs in a bit of a standoff. The American Diabetes Association piped in, saying folks just don't want to do a test that has them hanging around for a couple of hours. Our patients are different. They understand this 2-hour investment can save them 2 decades of healthy lifespan. And really, how much do you blame docs for not pressing the issue? They hear their patients' complaints about the extra 2 hours and they give up. And here's part of the key here. Unfortunately, most docs think that hemoglobin A1C is going to be enough. They're obviously not aware that the ADA, American Diabetes Association, again, has also said that A1C misses 70% of this problem. Let me repeat it. Did you hear that? The ADA acknowledges that A1C misses 70% of the problem diagnosing new diabetes. So, diving into the nitty-gritty of the OGTT insulin survey, we hit a snag right off the bat. Counting on lab reference ranges is like trying to navigate with a map that's missing a few crucial landmarks. The labs are playing a numbers game based on biostatistics, using standard deviations to draw the line between what's considered normal or healthy and what's not. Here's the problem. Using standard deviations assumes that only 2.5% of the population has the disease. Yet even the CDC and ADA, the Diabetes Association again, have said it's not 2.5%, it's over 50%, it's 52%. Others say up to 80%. So we see it all the time. Patients went to the extra effort to get definitive tests, but thought they were okay based on lab ranges. Unfortunately, they were just as sick as that 52% that had it. And yes, they were in the 90% that didn't know they had it. It's not just about catching a glimpse of your fasting blood glucose levels. It's about tracking the whole journey of those carbs from the moment they leave your plate until they're stored away in your liver and muscles. Again, relatively safely. When we talk fasting blood sugar, hitting over 100 signals prediabetes territory. And crossing 125, you're looking at full-blown diabetes as your diagnosis. But the plot thickens between 1 and 2 hour marks. If your sugar spikes over 140, welcome to the prediabetes club. I typically say 120 is optimal because it is. Evidence indicates, though, that regular time over 140 causes inflammation and plaque. and things like eye damage and nerve damage. So if you're interested in the ADA and the CDC standards, they peg prediabetes in the 140 to 199 range. And if you're soaring past 200, that's type 2 diabetes calling your name, no matter which group's calling it. Except maybe for most docs, they still don't know how to interpret those tests. Now, here's the kicker. Every one of these numbers is a signpost for potential tissue damage. There's a common myth that prediabetes is just a waiting room, just a touch of sugar, no harm done. But that's a dangerous underestimate. The truth is, prediabetes is already leaving its mark, a fact most docs just don't understand. So as we go through the insulin survey data, we're not just crunching numbers. We're piecing together a story of how your body manages or mismanages those carbs, setting the stage for what comes next. Checking your insulin levels as we challenge you with glucose is also one of our tricks. While many skip over the insulin survey and they're thinking it's too much, we dive right into it. We don't stop with glucose levels. We also keep a keen eye on insulin. Now, why add that extra step, measuring insulin? It's because this strategy, adding insulin levels, helps us to identify an additional 15% of folks who are struggling as they navigate these tricky waters of blood sugar and insulin balance. Our goal? We want to ensure that your body can maintain healthy glucose levels without having to pump the insulin like it's trying to inflate a life raft. When insulin has to go into overdrive, it's like a neon sign flashing insulin resistance, but only for those who understand. Initially, you might see normal blood sugar levels, but the insulin working behind the scenes is off the charts, trying to keep that sugar in check. This is our first clue that you have insulin resistance. It's not always about blood sugar levels. It's about your system having to crank up the insulin to keep those sugar levels safe, meaning your body needs more insulin than you would or should typically use. So if you find your fasting insulin levels tipping over 10, fasting insulin over 10, or any reading soaring past 70, it's time to wave the red flag. High insulin can be a saboteur, not just risking tissue damage, but also messing with your weight management efforts. We've seen it time and again. Folks coming in frustrated, saying, "I just can't lose weight, no matter how many calories I drop," with their fasting insulin levels hovering between 15 and 20. It's a classic tale of insulin resistance playing out in real time. Now, you might think these people are exaggerating. They don't know how much they're eating. But studies have documented that it's true. Their body's calorie burn rate just slows down to match the calories when they have high insulin levels. Now, if you're wrestling with metabolic disease, it's like your body's putting fats on layaway in your lipoprotein or cholesterol particles because it just can't seem to burn them, those calories, fat, carbs. Most docs believe that HDL, which they call good cholesterol, and LDL, which they call bad cholesterol, are just for cholesterol alone. But the plot thickens when we bring triglycerides into the spotlight. As metabolic disease cranks up, excess triglycerides, or fats, start piling up in those blood particles. The lipid panel with fractionation is our detective, uncovering where these triglycerides are hanging out and how they're bunking up. When triglyceride levels are high, it's a neon sign that carbs are getting the cold shoulder from your body, setting the stage for metabolic syndrome. This is the drama of insulin resistance transforming carbs into unwanted fat guests, stuffing themselves into the lipoproteins or cholesterol particles, cruising through your bloodstream. So, Most people focus first, or most doctors focus first on LDL particles and LDL particle numbers. That's even if they're getting this test. And it's unfortunate that they focus first on LDL or LDL small particle numbers, because those numbers are contaminated by the total LDL distribution. Again, you got to know a little bit of biostatistics and how the labs are counting things. Anyone with a higher LDL will have more total particles, including both small and total particles. The critical issues here are in the distribution of the sizes of LDL. More specifically, we want to know if there's any loss in large, fluffy LDL. That's the simple way to look at it. Are you losing large, fluffy LDL? We measure this from LDL peak size and LDL pattern. We're looking to see if you have an LDL peak size of at least 223 and a pattern or distribution of the A type. This signifies that you're not losing large, fluffy LDL particles. That's what we want to see. Most people think that particle size distributions, they think small, dense LDLs tend to sneak into the artery wall more easily, while the large, fluffy ones bounce off like beach balls. I personally suspect it's a little bit different. I suspect it's more of a loss of those large, fluffy LDLs, and that's really the bioindicator of metabolic disease, for reasons we can discuss later. The HDL large, efficiency experts. It's not just a numbers game with HDL. Size matters here too. HDL particles work to remove cholesterol from where it isn't supposed to be before it gets out of control, and even in the arterial wall, and getting it back to the liver. Large HDL are the most efficient form of HDL. Think of HDL as big tractor trailers, able to transport more cholesterol than their smaller counterparts. So, why do we bring this lab into the mix when other doctors just don't? Well, it's simple. The usual glance at HDL and LDL levels misses the forest for the trees. Focusing on particle size gives us a clearer picture of how your body deals with fats and carbs. It's a window into your metabolic health, highlighting issues like poor glucose metabolism and the underlying inflammation that sets the stage for cholesterol to crash into artery walls. This lab isn't just another test. It's a critical piece in the puzzle in understanding and managing metabolic disease. It offers insights that other tests just miss. At the end of the day, this lab is another biomarker. It increases the accuracy of our tests, and it tells us how your body burns carbs and fats. That's what we want to know about metabolic disease. Another test we use to find trouble in your arteries is the microalbumin creatinine ratio. Now, what's that, and what's being measured here? We're exploring how much protein, or microalbumin in this case, you're unexpectedly donating away into your urine. Real-time insight into the health of your artery walls. You see, if your arteries are inflamed, they likely let that protein, albumin, slip from your bloodstream into your urine. If proteins sneak through, the gate isn't as tight as it should be. In other words, the lining of the artery wall is inflamed. The more banged up this filter gets, the less it picks and chooses what passes. Now, here's where we zig while others zag. Many doctors use this test to check kidney function, but we're spotlighting it for a different reason: cardiovascular disease. So they're looking at high levels, 30 and more. We're looking at low levels, less than 3. So our eyes are on the microalbumin creatinine ratio, scouting, as I said, for what's called microproteinuria. That's a known risk factor for cardiovascular disease And we're telling you right now why. It's because that lining of the artery wall is inflamed. When the arteries cruising through the kidney start leaking albumin into your urine, it's broadcasting a distress signal. Those arteries are inflamed. But here's the kicker. It's not just a local issue. It's not just the arteries inside your kidney. If the arteries inside your kidney are inflamed, it's a worldwide tour, or at least a body-wide tour. Your whole body's arteries are inflamed throughout the network. The inflammation panel, spotlight, C-reactive protein, myeloperoxidase, LPPLA2. Sure, a few others turn to C-reactive protein, but they don't know CRP tends to have too many false positives. That's why we look at a complete panel, including CRP, microalbumin creatinine ratio, myeloperoxidase, and LPPLA2. So they look at the ones that think about inflammation at all, and we look at 4. Let's go deeper. High sensitivity CRP. It's the liver's way of sounding the alarm on inflammation. It's our go-to for an initial inflammation assessment. And again, as I said, for those very few doctors that do have some awareness of cardiovascular inflammation, this is what they use. A high CRP level, especially when it stands alone, might point towards an autoimmune disease like rheumatoid arthritis or psoriatic arthritis, or another condition like you had a flu shot 2 days ago, or you had a bump or a bruise. So sometimes it suggests the need for a specialist consultation. Sometimes it suggests the need to be ignored. Sure, a few others turn to C-reactive protein, but they don't know CRP alone tends to have too many false positives. MPO, or myeloperoxidase, it's the atherosclerosis architect. MPO works behind the scenes, creating oxidative stress. It paves the way for atherosclerosis. In other words, it's a player in the cardiovascular plaque game. Its role involves turning the typically benign LDL into oxidized LDL, a form that macrophages, it's a type of immune cells, in the artery walls find irresistible. This process kickstarts the formation of foam cells and the development of fatty streaks. Now, you may not have heard of foam cells or myeloperoxidase, but most of you have heard of fatty streaks. Those are the early indicators of atherosclerosis. We can test for what actually gets that process started. There's another thing that helps get that process started, another player. Both of these, MPO and this one, LPPLA2, are actually enzymes released by the immune cells who came in to clean up the problem. LPPLA2, as I said, is an enzyme released by immune cells. It acts as indicators of inflammation within the artery walls. It plays a pivotal role in the development of atherosclerosis. This marker suggests an uptick in inflammation activity, leading to the recruitment of inflammatory cells that feast on modified LDL particles, transforming again into foam cells, a critical element in plaque formation. Well, why don't other doctors use these? While traditional cardiovascular risk assessments rely on risk factors like age, cholesterol levels, smoking status, our panel looks at actual biomarkers, metabolic processes, and tissue damage. The broader medical community is not looking at MPO and LPPLA2 markers due to a mix of lack of awareness and a historical focus on more traditional risk markers instead of bioindicators and damage markers. Now that modern laboratory science allows us to see these actual bioindicators, this actual damage, this metabolic mayhem, why are so many doctors still stopping with risk? Risk factors might be classic in medical education, but Why settle for suspicion alone when evidence is available right there in front of your eyes? Elevated levels among these inflammation markers signal that your arteries are under siege, with plaque taking center stage. By integrating these insights with our comprehensive metabolic evaluations, we can uncover and address subtle health remixes, setting the stage for targeted intervention and care. Now that we've covered the primary labs we do and why, let's explore some specific examples of how we treat depending on your lab results. Now, one of the first things to think about is that we're not playing whack-a-mole medicine. What do I mean by that? Well, let's take a fresh look at this journey through the landscape of metabolic health with a bit of a nuanced lens. It's not about a simple checkbox and got it or don't got it, don't have it. We're diving deeper than that. Think of us as stepping away from that old school game of whack-a-mole medicine. Most doctors, with their focus and specialization, might zoom in, and they will. They'll zoom in on one particular spot. If you're a neurologist, you focus on the brain. An ophthalmologist focuses on the eyes. Cardiologists on the heart. Often they see a symptom or a single bioindicator like an offbeat LDL. What's the solution? Just hand out a statin, like it's a free ticket to the show. Oh, asthma? Here's your inhaler script. Pain? Oh, they've got a pain med for that. High blood pressure? Beta blockers are dished out, despite being out of date and a bit of a one-hit wonder. But here's the twist. While they're all about treating the beat that's out of rhythm, the effect, the symptom, it's like they're missing the song. They prescribe a pill for every hiccup instead of pausing to listen to the whole track, to understand the underlying cause. It's the underlying cause. It's not our style to ignore that. We use a broad range of tests to explore your metabolism from diverse angles. This enables us to move beyond treating just the symptoms. We aim to find and address the root cause, not just mute the symptoms with a quick fix. Now, diving into the nitty-gritty of our approach, we bring out big guns like OGTT, insulin survey, glucose tolerance tests. And we don't stop there. We also pull in a detailed lipid panel with fractionation and a cardiovascular inflammation panel to round out that picture. Now, the reason behind this multifaceted approach, it's all about the diversity in our genetic makeup. Genetic quirks lead some folks to ace certain health markers while stumbling on others, signaling that there's still a hitch in their health. This comprehensive scan gives us the upper hand in spotting and addressing metabolic diseases in a way that's thorough and nuanced. Now, our labs serve as a mirror for patients to peer into, and this revelation becomes the most potent form of treatment that we have, helping patients become motivated by understanding the landscape of their metabolic health or disease. Hard evidence laid out right in front of these patients has this unique power. Witnessing their own metabolic metrics, patients experience a profound awakening, suddenly motivated to overhaul various facets of their lifestyle. The reality that most of us grapple with metabolic disease is true, and it's largely due to our contemporary diet and lifestyle. That just cannot be overstated. Delving into lab results reveals that the established normal ranges merely mirror societal averages. However, if the majority are already in the throes of metabolic complications, these standards are not so much normal as they are indicators of a sick population. So we go beyond settling for average benchmarks. We target what's truly optimal, what epitomizes genuine health. Striving for these optimal lab ranges allows us to elevate our goals, moving away from conforming to problematic norms towards reaching an optimal state of health. Now, the importance of lifestyle. Over half of the reasons leading to premature mortality can be traced back to lifestyle changes within our grasp. Let me repeat that. Half of the issues that kill us too early can be changed by our lifestyle. Topping the list of lifestyle factors is diet, an aspect that stands in a league of its own. You cannot outrun, outlift, or outmeditate, or outsleep poor dietary choices. The first step towards wellness involves scrutinizing the carbohydrates you consume, aiming to limit glycemic carbs to under 100 grams per day. Understanding the impact of different carbs is crucial for making informed choices. Glycemic carbs, the ones that cause blood sugar levels to spike, that's what needs particular attention. While some vegetables like broccoli, cauliflower, Brussels sprouts, asparagus pack their carbs with beneficial fiber, others, such as even carrots and especially beets, may raise your blood sugar more than you'd expect. You need to test, don't guess. Integrating the fructose conversation into this narrative highlights the importance of choosing your carbohydrates wisely. Fiber-rich carbs slow down the absorption of sugar into your bloodstream and divert fructose to your large intestine, where it can be beneficial rather than detrimental. This approach not only prevents plaque buildup in your arteries, but also mitigates a series of health issues. Now, understanding as the key to adherence. We're introducing another aspect to this low-carb journey, understanding through tools like CGM. Remember a minute ago I said test, don't guess? What's a CGM? A continuous glucose monitor. It's crucial for sticking with it. Recognizing your body's response to carbs and lifestyle effects is the key. Accountability is important. We suggest accurately tracking your carb intake for 2 weeks. Sweat the details. It takes you less than 20 minutes each day. And days 2, 3, and 4 become a lot quicker after your experience with day 1. And it's not nearly as difficult as the days when we used to have to carry a paper calorie counter and carb counter. You've got it right there on your phone. So, there's a specific type of exercise, and let's talk about exercise for a minute. There's a specific type we recommend to round out your lifestyle journey. It's called high-intensity interval training, HIIT. A common HIIT protocol involves 60 seconds of intense uphill sprints, followed by 60 seconds of recovery. Repeat that 20 times over the course of a week. But if you're going, whoa, wait a minute, it's not just about uphill sprints. It's about adaptability, and adaptability is key. For those of us with joint issues, alternatives like indoor cycling, elliptical machines, or even certain resistance training machines, these can offer a viable path. HIIT, along with its cousin, REHIIT, or reduced exertion high-intensity interval training, this can be completed in just 5 minutes. These things tone down, the REHIIT protocol tones down this no pain, no gain philosophy that many people think are just too macho or perhaps even dangerous. It puts HIIT in a far more accessible format. These methods are not just exercise routines. They're akin to discovering a fountain of youth, particularly for the legs. These are the body's largest muscle groups. They act as glucose sponges. This is not about looking good. This is about protecting your arteries. These glucose sponges, these leg muscles, they play a critical role in protecting us from glucose spikes. They provide the metabolic safety net that we need. This makes active muscle groups an invaluable internal defense against metabolic disease and high blood sugar challenges. Now let's talk about body fat for a minute. Shedding body fat is a journey we embark on with our patients through various strategies. It's a key player in the arena of metabolic disease. The old school that pegged body fat as a passive, harmless energy storage tissue is flat wrong. It turns out that body fat's like a chemical factory pumping out hormones that create metabolic disease. We're talking about sophisticated sounding agents like adiponectin and leptin, and then there's resistin, a hormone that truly lives up to its name. It creates resistance, insulin resistance. The game plan that we lay out here encompasses diet, exercise, a big dose of accountability, and it's coupled with a wake-up call that we deliver via lab results. All of this forms a potent mix that proves its mettle in torching fat in ways that are often unheard of in other clinical settings. I've just felt like I've died and gone to heaven as a doctor with so many people that actually do the work and lose 30 pounds when they need it, more, 120, 150. Now, let's talk about some of the challenges in weight loss. For example, hitting a plateau or falling off the wagon. It's part of the human existence and experience. Whether it's life's curveballs like hospital stays or the loss of a loved one, indulging over the holidays, or caving under work stress, these moments happen. We fall off the wagon. The key is minimizing self-criticism. Remember, slipping doesn't spell the end of your health journey. The real enemy is lingering too long in that fallen state without mustering the focus and discipline to get up, dust yourself off, and hop back on that path to success. Hop back up on that wagon. Are you stuck on a plateau? That's a very different beast. If you keep on the same track, expecting different scenery, you'll find yourself jogging in place. Breaking free from that standstill often means venturing into uncharted territory, trying strategies you've never considered before. Navigating the fat loss journey comes with a map full of routes, and we're here to guide you to the one that fits you like a glove. Ever dived into the deep end of fasting? Beyond the typical intermittent fast, beyond 24 hours? Prolonged fasting might just be the secret weapon for blasting past that stubborn plateau. And if you haven't given high-intensity interval training, HIIT, or resistance training a shot, it might be time to shake things up. Even our seasoned citizens, who might not typically gravitate towards pumping iron, find that building a bit more muscle really turns up the heat on their metabolic furnace. Remember this: growing old is just not for sissies. Now, the customized playbook. Let's dive a bit deeper into our playbook for crafting a personalized health strategy for our patients. It all boils down to understanding exactly where each person is in their health journey. Take the conversation around cutting-edge weight loss, solutions like Ozempic, for example. Yes, we're on board with those breakthroughs, but they come into play after we've maximized lifestyle modifications. Picture this: two individuals, both weighing in at 180 pounds, with a target of 150, identical cholesterol particles, and matching glucose tolerance tests. The first is embarking on their journey just now. They've never reached the rigors of HIIT training or the discipline of carb management. The second is in a different space. He's already lost 40 pounds from an initial 220. His body's hit a snag, and he's got a relatively high fasting insulin of 15. This warrior, having demonstrated commitment and progress, might be a better candidate for an Ozempic nudge. And by the way, They say once you've had these weight loss drugs, you're stuck on them for life. Don't say that to my patients. It's just not true. Understanding a patient's emotional and mental readiness is just as pivotal. A case in point, last week I encountered an octogenarian, somebody in his 80s, who, by sheer genetic fortune, faced minimal metabolic issues until recently, despite significant obesity. So his lipid fractionation unveiled some concerns. For him, the medicinal route might present the least resistance, marrying effectiveness with ease. It's reminiscent of customizing training for an athlete. First, you tune into their unique story, gauge their readiness, and only then do you tailor your tactics. It's about adding layers of personalization to your approach, ensuring that we're not just applying a standard template, but weaving a health strategy that aligns perfectly with where the patient stands, what they're ready to tackle, and where their next steps work. Now, here's some examples of how we treat things and that we look at. For example, CIMT. Let's crack open our playbook for the first thing we look at, a CIMT. We're about to give you a peek behind the curtain. This test, the CIMT, is a secret agent for scoping out soft, sneaky plaque. It's lurking in your arteries. Soft plaque is the problem. Calcified, stable plaque is about as safe as not having any plaque at all. So where do we go from there? Our go-to might be suggesting low-dose statins for those sporting some arterial artwork. Now, we get it. Statins are like the one band that everybody loves to hate. Their rap sheet in court of public opinion is longer than a grocery list. But here's the kicker. While statins, metformin, and their drug buddies can join the party, they're not the guests of honor. That title belongs to lifestyle, and as we said, mostly diet. Lifestyle is the king, queen, and ace of the health deck. Why? Because the evidence is stacked higher than a house of cards. Randomized clinical trials, the gold standard of prove it to me, show time and again that lifestyle beats the band. So if we offer a metformin or statin and you're not feeling it, that's no sweat. We're not here to push pills. We're here to push progress, lifestyle-wise. That's where our hearts and yours should truly be. Now, here's another thing we look at. OGTT and insulin survey panels. Imagine you're giving your blood sugar a little nudge with some carbs and watching it hit the ceiling. That's your body waving that red flag about its carb handling capabilities. Hello, insulin resistance. It's like throwing a party with too many carbs. And your arteries, well, they're not too happy about it. They start acting all inflamed, becoming the kind of sticky mess that traps fats or those pesky, small, dense LDL particles right in the artery walls. The take-home message? It's time to cut back on the carbs and keep an eye on your sugar levels with a CGM, especially if your glucose or insulin levels are too high. Now, remember the components of the test. Maybe your glucose challenge doesn't cause too much of a stir, but your insulin levels skyrocket to 3 or 4 times optimum. It may seem like your body's insulin response is overzealous, but if that were the case, your glucose would tank. That does happen, but not very often. Insulin highs set the stage for trouble, marking the early scenes of metabolic disease. Our recommendation for this is to be aware that using a CGM doesn't mean there isn't a silent storm brewing in your arteries. It's a classic case of hyperinsulinemia playing the villain, stealthily causing carb havoc even when blood sugar levels appear to be normal. The third thing that we look at for treatment is elevated LDLs. Now, when we see those, we pause and ponder, might you be a lean mass hyperresponder? It sounds like a superhero trait, right? Well, in a way, it kind of is. It's all about genetics, and again, those genetic quirks. You cut down on carbs, your body shifts gears into a whole new metabolic vibe. LDL suddenly turns into the boats that carry your metabolic currency. It's your Uber shuttling around, and bam, it looks like a red flag for LDL concerns. Your doctor goes off the reservation, upset, telling you you're killing yourself. And here's the plot twist. This lean mass hyperresponder thing, it's still fresh off the science press, still being figured out, but it doesn't look like those high LDLs are causing risk. On the flip side, traditionally, high LDL has been the bad boy of blood tests. It's been the old school metric. When things get started going south in metabolism land, LDL starts packing on the pounds by adding triglycerides. Up goes LDLs. Alarm bells start ringing for cardiovascular disease. High LDL in the company of those inflamed sticky arteries, that's the kind of duo that kicks off the cascade, rolling out the red carpet for atherosclerosis, or plaque, to make its grand entrance. The fourth thing we look at involves niacin. This over-the-counter marvel is no shy contender in the supplement ring. It's the only thing, prescription or supplement-wise, that can lower Lp(a), hike up HDL, take down LDL, and slice through triglycerides. You can see why it might be seen as the Swiss Army knife of cardiovascular supplements. Still, we don't reach for it as often as some. It is our second favorite supplement, right behind vitamin D. Thanks to its potential side effects, we're not handing it out like candy. There's got to be a solid game plan for using it. The fifth thing we look at, elevated homocysteine. Now, it's been a known cardiovascular bad hombre or risk factor for years. That is, elevated homocysteine. But only recently we have figured it out. It's methylation. It's another genetic variation issue. It's called MTHFR. For the biomedical geeks, that stands for methylene tetrahydrofolate reductase. It's all about how our bodies extinguish the wildfires of oxidative stress, which is the leading act in the drama of type 2 diabetes and prediabetes. Remember in the Robert Lustig interview, we were talking about the redox metabolism of diabetes. Well, this is it. If homocysteine levels are riding high, we're likely to suggest supplementation with methylated B complex vitamins. On the flip side, methylmalonic acid plays its own unique tune, especially significant for the older crowd or those on metformin, potentially messing with B12 absorption and risking nerve damage and anemia. Now, for the vitamin B12 chorus, it's not just about how high or low level the level is. The real showstopper here is methylmalonic acid. That's the test to get. It's a low score. That's what we're looking for. When it's low, B12 is hitting the right notes. The sixth thing we look for, AST and ALT. Here's the rhythm section, AST and ALT. These guys are hitting high notes more often now. These are liver tests. Thanks to the new chart-topping illness known as non-alcoholic fatty liver disease. Yep, you heard it right. Our modern-day metabolic mess, starring pre-diabetes and diabetes, has now outpaced alcohol as the leading cause of liver encore performances, from cirrhosis to liver cancer. Back in the day, an ALT level of 24 was a problem. Now, labs are listing normals up to 40, just because this metabolic tune has become an all too common part of our sick population. Now, referring you to experts, people ask, have we ever handed off to another expert? The answer is a solid yes. Kidney and eye doctors are our most common referrals. I'd say that's about 10% of significant cases. We often work alongside arthritis specialists as well. Now, does that surprise you? It surprises most doctors too, because they don't focus on inflammation. They're usually not aware that certain inflammatory diseases like rheumatoid arthritis or psoriatic arthritis create as much risk for cardiovascular disease as full diabetes. Both the rheumatology crowd and ours end up watching HSC reactive protein in these cases. CRP often drives treatment decisions for the rheumatologist, while for us, it's a critical part of that overall cardiovascular inflammation monitoring program. Our goal is to make sure you get the specialist input tailored to your health's storyline. The history and over-focus on LDL. I get a call once or twice a month from someone perched on the edge of panic. More often than not, it's a friend of a friend. That's the breadcrumb trail leading them to my phone line. Their doctor's been sounding alarm bells, all because they decided to cut a few carbs. And lo and behold, their LDL shot up. That's a known thing. It doesn't appear to mean damage or even risk. Now, let's rewind back to 1955. John Goffman, a doctor and physicist from UC Berkeley, rolled up his sleeves and introduced the analytical ultracentrifuge. Humans do this all the time. We apply tools from one area, like physics, to another, like medicine. So, where do you think the following things came from? X-rays, radiation treatment, ultrasound, CT scans, MRI. All of these came from physics, and they were applied now to medicine. So, Goffman applied an AUC, analytical ultracentrifuge, to blood samples. It was capable of sorting cholesterol-carrying particles by density. Goffman created a whole new branch of cardiovascular risk science focused on cholesterol particles, or what the doctors call lipoproteins, and their density. Or at least, so it seemed at the time. We were off to the races. It was a classic case of what gets measured gets fixed. Unfortunately, there are pills that fix LDL cholesterol without all the hard work of adopting a healthy lifestyle. This created a type of bias called partial observation bias. In doing so, it created major confusion in the area of causality, or what's really the cause and what's just an effect. It incorrectly targeted an effect or an outcome of metabolic disease, the LDL cholesterol, as the cause of cardiovascular disease, and therefore disability and death. So the result has been decades of overdependence on statins, when lifestyle should have been the focus. Yep, the tail wagged the dog. So here we are, decades later, still tangled up with LDL because of a tale that began with an ultracentrifuge and a glimpse into the cholesterol particle world. The ease of measurement led us down a path where LDL became the main character. We're humans. Humans love shortcuts. We wanted a single test like bad cholesterol, and a simple treatment like a pill, like statins. Shortcuts sometimes pay off. This time, they didn't. If metabolic turmoil is steering the ship and LDL is just along for the ride, zeroing in on LDL can actually end up doing more harm than good. It turns LDL into a scapegoat, a decoy, used by metabolic disease to stay under the radar. We end up in a skirmish with LDL, armed with medications, while the underlying metabolic disorder smirks in the shadows. Tackling LDL with medications while ignoring metabolic disease is a road to heart attack, stroke, disability, and death. As it turns out, those LDL-focused meds, like statins, aren't just missing the mark on metabolic disease. They even nudge you closer to diabetes territory. In other words, the treatment can make the real disease worse. So think twice, and then think again about using medications alone for the number one killer and disabler. Genetic conditions and LDL. Peeking through the genetic kaleidoscope, sure, high LDL might pose some cardiovascular risk, but it's not the blockbuster threat it's been made out to be. So let's not overlook the outliers in this narrative, like the cases of familial hypercholesterolemia, or FH, especially the jaw-droppingly rare homozygous variant where teens can face heart attacks. No question, high levels of ApoB are troublemakers here. Yet these instances are exceptions. They're not the norm. They show up in about 1 in 40,000 folks for homozygous familial hypercholesterolemia. This isn't your everyday cholesterol chat. It's a whole different ballgame. The real plot twist? Doctors have been chasing after LDL like it's the main villain, when the real troublemaker, metabolic disease, has been hiding in plain sight, using LDL as its cover. Hypertriglyceridemia. It's too many fats or triglycerides in the blood. It throws another curveball into the mix, born from genetic quirks as well. Then there's that crew of lean mass hyperresponders, growing with the popularity of low-carb diets. They are a fascinating bunch. They're rocking similar plaque levels without the drama you'd expect from a sky-high LDL. That's if high LDL were the puppet master of plaque and disease. These outliers with LDL levels off the charts would be in the spotlight for all the wrong reasons. Yet here we are, eyebrows raised, questioning if LDL's role has been miscast in the saga of cardiovascular health. The role of ApoB in metabolic health. Venturing further into this saga, the spotlight shifts slightly from LDL to ApoB. The lipidology geeks proposing ApoB argue that it's a superior marker. It's a superior marker, cutting closer to the heart of metabolic disease than LDL ever could. They point out that VLDL, the so-called remnant cholesterol, is the real villain here, with metabolic disease pulling the strings behind the curtain. ApoB's ability to capture this story element offers a fresh perspective. It is a nod to the fact that it's been metabolic disease all along. But here's the thing. Effective metabolic disease evaluation requires far more than just a simple ApoB. So yes, ApoB is better than LDL. There's no question here. It's just that if you want to evaluate metabolic disease, ApoB is just not adequate. Cardiovascular and metabolic health assessment are big, complicated issues. It's more than just your cholesterol level. We haven't even mentioned some of the basics like dental health, thyroid health. If you want us to train your doctor, we're open to it. We even have a website and a YouTube channel for this. I've done that most of my career. In fact, I've been training docs in prevention for more than 30 years. 30 years ago, I ran the postgraduate preventive medicine residency program at Johns Hopkins, the best place in the world for this, for teaching exactly what we're talking about. But here's the thing. Most doctors just can't or won't take the time to learn something new. We have received numerous inquiries from individuals interested in becoming patients at our practice. Many of our patients come to us feeling misunderstood or neglected by conventional medicine, often receiving only a Band-Aid approach from their doctors. Moreover, a significant portion of our patients felt like they were flying blind due to inadequate biomarker tracking or interpretation, resulting in ineffective, dated tests dictated by insurance companies, and for the most part, useless. If this resonates with you, I encourage you to either give us a call or simply click the link below to learn more about becoming a patient. Our practice is dedicated to identifying and addressing the root cause of health issues through a comprehensive testing protocol. We'll guide you through the process from ordering the necessary labs to interpreting the results and providing personalized risk evaluation for conditions like prediabetes, insulin resistance, metabolic disease, cardiovascular risk. So again, if you want to learn more, sign up today using the link below in the description below, or give us a call at 859-721-1414. That's 859-721-1414. Or go to prevmedhealth.com. That's prevmedhealth.com.